the axis cavity, and probably Bart will show you later how to redefine the axis cavity. What I want to say here is that it is very important for us to make a good axis cavity, a state-of-the-art axis cavity, because if we don't enlarge it enough, we will not find the canals and we will have issues later on. If when we are doing a retreatment, we enlarge it too much, like here, for example, on this premolar, we will do procedural errors, and you can see where the arrows is that we have here a vertical fracture, obviously, because the axis cavity was very large, and of course, there was a post there. And we see cases like this one in many times. Here, for example, an MOD cavity with a fracture in the middle of the tooth. So we have to take into consideration this. It is very important because when we do a root canal, it is important that the tooth later on will be functional. It's not only root canal to do just a root canal. And the main idea Bart was asking me at the beginning of the root canal is to recover the anatomy. Someone before us worked on the tooth. Here you can see on this upper molar, for example. In the mesial root, the first clinician during the primary treatment went a little bit inside the canal only, and one of the canals, and the rest of the root was completely empty. Now, after doing an axis cavity, removing the material there, we will be able to find both canals. So we should do this for every single tooth that we are working on. And in any tooth, we can have supplementary canals. So we should do it every time. Coming up to the topic, my topic here during this presentation is after taking an X-ray, deciding to do retreatment, we want to access to the filling material. So the first step when we want to access to the filling material is if we have a post. Sometimes we don't have a post, but if we have a post, we have to be able to remove this post, and we have to do it easily. Okay, here, for example, we have a case of a screw post. This is what we call a screw post. It is usually yellow, but of course it's not gold. And there is many techniques to remove it. We can use some removal kits, like the Ruddle kit, or we can simply use ultrasonic tips. But before using the ultrasonic tip, it is important to remove if there is any restoration, like composite restoration, for example here, to remove this restoration without touching at all to the dentine, because we want to be conservative here. So I am removing the restoration with this long burr to be able to see under microscope what I am doing. And after doing this, by using an ultrasonic tip, here for example, you can see that we will do a counterclockwise movement on the tooth, and progressively, under water of course, because we don't want to heat up the tooth while we are working. Always keep in mind that we have to repair without destroying anything. And then slowly the post will come out. Sometimes we have to be a little bit more patient if the post is really very well fit inside the canal. And as you can see here, at one point, we are able to remove the post, of course, either isolation. And you can see on the post we have some cement there that were on the post because the first clinician placed some cement. After we do this, the treatment, because it's just a central case, it's easy. But we have to adapt our shaping to the particular anatomy of the tooth. Here, for example, the canals were already very large. So in this case, I use the Endostar to finish the Endostar 4004. Why? Because I want to remove all the material that were present before inside the canal, and I want to clean very well the entire system of the root canal. Another kind of post is what we have metal posts. Metal. This is a case of a metal post, but it was a little bit a strange post because it was a prefabricated metal post, just a post like this one, and there were amalgam all around the post. This actual publication of Silva and al. Showed very clearly that by using ultrasound on this kind of post, can be gas post and core, or it can be just a prefabricated post, we can reduce the retention of this post. And they concluded also that the nature of the cement, like glass ionomer or polycarboxylate or oxyphosphate, does not interfere with the retention, or if the post is very large or very long. So what is important is to use some ultrasonic tips, even if we want to use any removal kit, because it will reduce the retention, so it will be easier to remove the post here. And in this particular case, we had to decide to do root canal retreatment, non-surgical. Why? Because the crown was not good. There was some decay all around it. And also, we looked at the first X-ray and we saw that the canals were already very large. So when these canals are already very large, we need to clean everything that is in the canal. We cannot leave any filling material. But we will end up with a situation where we have large canals, so the shaping is not the ideal shaping, not because of us, but because of what we have to deal with. So the first step is to remove the amalgam. Of course, this should be done under rubber dam isolation, especially when we are removing amalgam, because you know that by removing it, we will have lots of mercury, and we won't want the patient to swallow this material when we are working on it. So progressively, we will remove this amalgam, and at one point, we will see the post. Here, for example, we remove the amalgam, and we are seeing progressively the post. And here is the post, and you can see some gutta percha all around the post. So we are using the same ultrasonic tip. I like to use simple tools because we want to be ergonomic, not to have too much material. Same ultrasonic tip. And we will start to remove the post, as you can see here. And at what time the post is out. But this doesn't mean that we finished our work, because look at the cavity, how it is. All gutta percha, there is some decay all around. So we have to take care of this after removing also the post. So we remove the gutta percha with an ultrasonic tip, and then we are using this kind of burr to clean all the decay, to be sure that we are working on a clean fill before going inside the root canal system. And then even after doing this, you can see inside the canal, the palatal canal, where the post was, that we still have some cement there. You can see the color of the material. It's not pink, so it's not gutta percha. So it is cement. This is very easy to deal with. We just need some magnification, and we will use this kind of ultrasonic tip, which is like a spreader, and go there under magnification. We will see where the color is, because this color means that there is the cement there, and we will remove it. It is very quick. At one point, we will see the gutta percha. When we see the gutta percha, we will visualize it. We know that it is the treatment becomes easy because we know how to remove gutta percha, and we will see it later on during this presentation. So this is the treatment after removing and after our 3D obturation. Here again, I told you the canals were very large. The two MB1 and MB2 were joining, and all the canals were very large. So in this particular case, we used for the apical obturation filling an MTA plug. And I encourage you to read this great article of Torabinjad and Damer, showing that the MTA plug is still the best filling material in cases like this one, when the canals are really very large. So here I am showing that the MTA plug in the palatal canal, but I did the same for all the canals. And this is the final X-ray. You can see that we have a difference in the radio opacity between the backfill, which was done with Obtura 2 gun, and the apical part, because we have less opacity with the MTA plug. But still, all the canals were filled. Here you can see in the palatal canal, in the mesial canal, the two joining canals, and in the distal canal, the MTA plug after doing our retreatment. Another situation, and this will be the last situation of post removal, it is This is becoming more and more often because everybody is using this kind of posts, which are the fiber posts. So for the fiber post removal, some people suggested to use retrieval kits. I read a few days ago also an article about guided endo to remove this fiber post, and also sometimes we can use, they are proposing to use a laser to remove this post. But for me, as I told you, if we want to go simply, we have simple tools. The same ultrasonic tip can be used in cases like this one. Not to remove the post, but to eat the post inside the canal, also under magnification. But before doing this, and here I am doing it through the crown, before doing this, we have to clean everything in the access cavity and to be able to visualize this post in this case. So here we have a composite core. We are removing the composite core, not using at all burrs here, not using at all burrs, only ultrasonic tips. Removing this composite burr. This ultrasonic tip is coated, diamond-coated ultrasonic tip. It's like a burr, but we have a good access inside the canal. And then at one point, we will see very clearly the fiber post, which is in the distal canal. Here again, I will use an ultrasonic tip, but it will be a smaller one. So this one that I use exactly the same to remove the cement. So it's like a small spreader. It will go away inside, and I can see what I am doing when I am working with it. And we will alternate water and no water. And what we will see here is some fibers coming out from inside the canal. When we see these fibers coming out, it's a good sign for us because it means that we are not digging inside the dentine. We have the feeling that we are digging inside the fiber post. This is done usually very, very quickly. And at the end of the treatment, we can perform our retreatment. Here, for example, in the distal canal, we finished our treatment with a 3504 because the apical diameter was large. And on the mesial canals, we finished with 2506 because the apical diameter was different. So in the same tooth, obviously, we can use different shaping instruments. These are the Endostar's instrument, heat-treated, that you can use in a case like this one. Now, we remove the post. We define the access. Probably Bart will talk about it later on, how to redefine the access. Now we are inside the canal. Inside the canal, we have another issue. Most of the cases we are dealing with are gutta percha. But gutta percha is very easy to be removed from inside the canal, but it is very difficult to be removed entirely from inside the canal. And here you can see some micro CT cuts that I did for a study about this topic. We can see that after removing the gutta percha with a mechanical system, we have still some gutta percha on the walls. The second cut, on the second cut, is after mechanical removal. And on the last cut, we can see some debris inside the canal, even after activation of the solution, irrigation solution inside the canal. These are 3D reconstruction also done by using the micro CT. You can see this canal is obturated, it's filled with gutta percha. And we can see the mechanical removal, and finally the activation. And still, we still have gutta percha after doing this activation. So why I am showing this? I'm showing this because I want to emphasize on the idea that it is very important for all of us when we are working on retreatment to be very picky, to be patient, to take our time to remove all the material during the retreatment, to look with the microscope to be sure that we remove on everything. And this is a very nice study by Castro and al. That showed that this material is even more difficult to be removed inside the isthmus and the anastomosis of the root canal. Here you can see in red, for example, the sealer material that stayed inside the canal on confocal microscopy after doing our retreatment inside the isthmus of mandibular molars. So this is extremely difficult. And we also show it in micro CTs that I did with the St. Joseph University group. And you can see that there is after removal of the material in the middle of the canal, between the two canals, in the isthmus, still material, so it confirms the study of gastroendal. And this is another view of this micro-CT showing the isthmus, that in the isthmus and the apical part, it is very difficult to remove the material. Other images, inside the canal, this one, you can see gutta percha after mechanical removal in the coronal part and in the apical part. So clinically, what does it mean? It means that we have to clean very well. Now, to clean very well, we have different systems. We can use exclusive retreatment systems, or we can use shaping files in retreatment cases. So first of all, in exclusive retreatment systems, here you see this lower mandibular molar. I use the retreatment of the Endostar, Endo, and it is a very interesting system because we have 4 files, and the first file is a 3012. So if we have a large canal, like a centra, for example, or this molar with very large gutta percha material inside the canals, we can use at the beginning this to create like a reservoir inside the canal and to be able to remove the coronal part, only the coronal part of the material. So this is the 3012. And as you can see, we removed a lot of material from inside of the canal, just in the coronal part with this first file, which was 17 millimeters long. So these files are used only in retreatment cases. They are stiffer than the normal files that we are using. So we have to be more careful when using them. And then when we are in the middle of the canal, we can use the 3008. Also the same, 300 RPM, I am using it. And you can see that we are removing in the middle part some more gutta percha. Of course, we don't go with the 3012 inside the middle part of the canal because it will be it will not be conservative for our treatment. And then we will go with the 3006 in the apical part of the canal. The first 2 files, they have a square section because they want the company wants more stiffness. And this file, it's a double S section. So it is more flexible because we want to be more flexible in the apical part of the canal. And you can see some material. Of course, we have less material coming out when we are using this file because we have less material during the when they first did the treatment. We have more gutta percha in the coronal part. Now, what we can do also is to use, and we have many articles talking about this, and we can use shaping files in retreatment cases. What is interesting by doing this? Because if we have curvatures inside the canal, more difficult canals, these shaping files usually are more flexible. Here, for example, I am talking about the Endostar system, the Endostar shaping system. We can use, for example, this file, the 3008, which has a nice taper, but also it is flexible. So we can do less procedural, have a difficult case. And as you can see on this picture, we were able to remove the gutta percha from inside the canal by using this file. This is in the distal canal. See the gutta percha coming out, more gutta percha coming out, and finally even more gutta percha coming out. And this is the final result. It is my last case. This is the final result. You can see that after removing everything, cleaning this type 2 configuration of Bertucci in the MB, in the mesial canal, we were able to place new fiber posts and a new crown, closed crown. And this is a 3-month follow-up of this case, done from zero, from the beginning, from the Endostar system, and finished with the Endostar system. So we are using the same system to do the retreatment and also the shaping of the canals. I want just to finish my my presentation by saying that we want to repair what we are doing, and this is something that my father, Professor M.Kaloustian, told me. I hope he is listening to me now. It is important to repair, but without destroying, like they did here, for example, for the Bensky. You know, the Bensky picture, he sold it, and when someone bought the picture, it destroyed instantly. This is what we don't want to do when we are doing primary treatment or retreatments. But I don't know if your technical issue is solved, because I personally finished my presentation. So I am waiting to hear from you now.
Well, Mark, I hope. I don't know. How do you hear me now?
Now I hear you. Now I hear you well. I don't know if they hear you well also.
Okay, I hope. because I changed everything. I was hearing everything. There is echo. Mark, can you mute your microphone for a second?
Yes.
We'll check it. Well, how about now? Ladies, is it better? We'll have to check it. I believe better. Okay, now it's good. Okay, so Mark, I was listening to all your presentation, and honestly, of course, we did our discussion before we stick to this presentation. But honestly, this is my first mutual lecture with Mark, and we have so many same opinion about the many topics about the retreatment. So I am surprised, because I have even done my presentation a bit earlier than Mark did, and many things that I want to show you I've already seen on Mark's presentation. So I believe this tells us that we have good ideas. So I will switch one more time to the presentation and go back to the retreatment and to reshaping the pulp chamber and the access cavity. So, as Mark mentioned, we have to do it in a very wise way, in a very smart way, let's say, because on the one hand, we have to make good visibility. On the other hand, we shouldn't enlarge it too much because the vertical root fracture can appear. So we need to stay balanced and make some kind of access cavity which allows us, on the one hand, not to miss any canal. On the other hand, we have to stay with as much tooth structure as it is only possible. And you can see on the main picture the beginning of the opening of the tooth, which actually was a retreatment but I don't know why there is a cotton pallet inside the pulp chamber, which was very surprising for me. So after removing the pulp chamber, the cotton pallet from the pulp chamber, we have image like this. So we have a lot of endometazone and a lot of dentin, which should be removed to visualize, for example, MB2 canal, which is marked on the image. And we have some different tools to do this. One of the most important and most useful tool is access cavity tip, ultrasonic tip with diamond coat. Mark shown you some different tips for the post removal, for removing the percha. There are many tips that we can choose. So I believe everyone will choose something for his own practice. Personally, I like diamond coated with the shape that you can see. There are many manufacturers, many types are available, but the diamond coating gives us very good work, very fast and very efficient. Of course, there are alternative tools. For example, very small burrs. The set of Mounts Discovery burrs is one of them. We can use them also. Some dentists say that they are even better because they are not producing that much ash from the dentin, so it's a bit easier to use them. Okay, I can agree, of course, but on the other hand, the visibility that is available thanks to the ultrasonic tips is much better. So the case I wanted to share with you is a case of a treatment of first upper molar with quite a lot of missed anatomy. On the one hand, as Mark mentioned, we have to remember that the more tooth structure we have after the treatment, the better for the outcome. Of course, I totally agree in 100%. But on the other hand, there are some important factors such as removing caries, and sometimes after removing caries, your tooth can look like this. Of course, I know that that's the kind of compromise, but still we know that in many cases we have to deal and treat also cases like this and try to give the second life, the prosthodontic buildup, and we pray from every year for another recall X-ray, which will show healing and no symptoms of the vertical root fracture, for example. So I want you to watch, not only see, but watch the pulp chamber, and you can see that there is a lot of filling material, mostly gutta percha and some kind of sealer, I believe the endometazone sealer, and some undiscovered places. And these places are the most interesting. This is the MB2 canal, for example. This is one of the spaces. You can see the transformation of the pulp chamber, of the look of the pulp chamber, after removing a huge amount of dentin, actually, between the MB1 and MB2 canal. There is small isthmus, which is calcified, and the space we need to remove is located far away the mesial wall before the line which connects MB1 and palatal canal. This is the place where we search for the MB2 always, and you can compare the image on the left side and the image to the right side. That on the right side we have much more dark color on the pulp chamber floor, and on the left side you can see that there is much more white dentin, which means that the dentin was positioned so it came, let's say, in the most easy way, it came and it's lying on the pulp chamber floor. So we have to remove it, as I mentioned before, ultrasonic tips or Mounts Discovery burrs. In this case, you can see how much dentin was removed. This is this space, quite a lot of. Okay, we can go further, and you can see that not only the MB2 was missed, but DB2 also. This is the 5-canal first upper molar. It happens like I believe no more than 3% of the cases. So this is pretty rare situation, but if we'll think about the failure factors of the primary treatment, missed canal is one of the most important. So every time you go to the retreatment case, you have to ask yourself a question, why do I do this retreatment? And as Mark mentioned before, I do this retreatment to improve something. So if the canal was missed, I have to improve it and find it. So this is one of the most important factors. This is how it looked before, and this is how it looked after 6 months. You can see the healing. The distal lesion is completely healed. The mesial lesion is smaller, but still healing. And actually, in the first version of our presentation, this had to be the first case that you were supposed to see. And now the part that Mark already told you should start right now. So now you have to remind all the things that Mark said, and he had beautiful images of removing gutta percha. And this is very important for the data, for the researchers, for collecting the information, how the gutta percha is removing. You have seen beautiful images of the small pieces of gutta percha that was re-aiming on the root canal walls. So because of this, let's say, or system of removing or findings that you already know, I divide my gutta percha removal protocol into 3 stages. First of all, we need to make the canal patent and remove the most volume of gutta percha, and this is when I'm using the Azure files, and then we can start and do something more. And the something more, the second stage, is always ultrasonic irrigation. No other idea of the agitation or activation of sodium hypochlorite cannot remove that amount of gutta percha than the ultrasonic tips can. And we have many different ultrasonic tips. In the very beginning, we can use diamond coated, we can use, as Mark shown you, the spreaders, and we can also use the sonic files, which are the files in the ISO size like 30, 35, as you can see on the image. And this is the second stage, and this is mandatory to every treatment. Remove the gutta percha of the files, and then to remove re-aiming gutta percha of the ultrasonic files. And now I want to share you a case. This is a retreatment case with a post removal, but it isn't the most important. Doesn't make too big difference, because the idea, as Mark mentioned, is the same: to improve. And we have tooth with quite a big lesion. We have internal and external resorption of the mesial root, so the inflammation is quite big. So let me go with you through the case. We are removing the crown, we are removing the post, and as you see, for the first stage, we have a lot of sodium hypo activated with ultrasonic tip. Not only activation is going on, but still the removal of the filling materials, quite a lot of endometazone, some kind of cements on this stage. Then we can go and remove it with files. You see the Azure file in action, and one more time the ultrasonic tip activating the sodium hypo. You can see a lot of small drops, because at this stage you have to use a lot of energy to activate the sodium hypo. And then there's very important stage. Of course, we are not able to perform micro CT during the treatment, because we would have to extract the tooth and send it to the university. But we can make an X-ray in the one projection, maybe in the distal shift sometime. And this is very important for me because sometimes in the isthmus there can be hidden sealer or small piece of gutta percha. Usually, maybe not in 100% of cases, but usually it can be visible. And on the root canal space, you can see some kind of white small lines, and this should turn on, the small yellow light in your head that something could be missing, something could remain. So this is important stage. And as I mentioned before, there are two mandatory stages of removing gutta percha. First of all, the gutta percha removed with your files, then gutta percha removed with your ultrasonic tips, and then if something is remaining, and in many molar cases it is remaining, you need to use some solvents. And you can use the gutta cleaner, which is the orange oil, which is very safe for the patient, very safe for yourself, and you can use it, for example, mixed with sodium hypo, drop by drop, and also activated with the ultrasonic tips. Then you are able to clean even more. So this is the mandatory stage, especially in the molar cases. So I have activated my sodium hypo, I have activated my solvent, then I removed all the liquids, dried the canals, placed the sealer, placed the gutta percha, and this is how it looks after filling. Of course, there's a lot of material that has been pulled out the canal, but this is the bioceramic sealer. As I mentioned before, we had internal and external resorption, so I decided to use premixed bioceramic sealer, and even after the extrusion, everything is fine. So this is on the left side, this is before, and on the right side, this is 6 months after. You see the healing, you see the fresh bone, so everything looks pretty great. And this is the image we are waiting the most. This is the image of healing, and we love it. Okay, I have a question, so I will answer briefly right now because there are some more questions to Mark. After the treatment, should we give information about prognosis to the patient, and how can we do this? First of all, I'm making the prognosis always before the treatment, always before the patient is paying me. Of course, I cannot be 100% sure. Maybe I will switch here. I'm not 100% sure if my prognosis is correct, so I can make it from here, let's say from here to there, yes? So I can say 50 to 70% for healing. I can estimate the healing at least if I have during the examination, if I see that there are missed canals, that the coronal sealing is poor, the quality is not good. So I can say to the patient that I can go from the beginning, the day we are meeting, after my treatment, I can go and make big progress. Or on the other hand, I can tell that I'm very sorry because the treatment looks like a very good quality treatment and still there's lesions, so I'm not sure if I can help. So you have to estimate every single case. What do you think about it, Mark?
I completely agree with you. And I will add just one thing. If there is any irreversible iatrogenic error when we, on the first treatment, like for example, a canal transportation, what we call a zipping, for example, of course, the prognosis will not be good because we cannot correct this. It's something, if you have a fractured instrument inside the canal and we are able to remove the fractured instrument, the prognosis is better than when we have something like this. Perforation, strip perforation, canal transportations, all these cases, everything should be explained to the patient. And there is many articles that showed very clearly this. Say, when you have irreversible iatrogenic errors, the prognosis is really not good. In cases like this one, we should use surgical retreatments.
I know the article you mentioned from our godfather Fabio. the very famous one from 2004, I believe.
Yes.
Yeah, exactly. So, Mark, please answer your questions. There are many questions to you.
I have a question about the after the retrieval. Can we play the retrieval of metal post? Can we place another post, a fiber post, for example? I think yes. There's no problem. What is very important, in my opinion, when we have to place a new post, is to prepare well the post space and to clean very well the walls where you want to put the post, especially if you are using zinc oxide eugenol sealers. So in most of my cases, I am using actually zinc oxide sealers, which are I'm using the pulp canal sealer, or now I am using also the produit dentaire sealer. In cases like this one, it is very important to clean very well the bro. I can use some micro brush. You can use products like the orange oil that Bart showed, for example, then some alcohol. Make sure that everything is clean to have a good seal of the new post. But I don't see any contraindication of using a fiber post. What do you think about it, Bart?
Well, I totally agree. I use the fiber post in most cases. It's primary treatment, retreatment, it doesn't matter.
Yeah.
Exactly.
I have another question about in practice when we retreat and we have a big size. This is the case I showed. Can we only clean without enlarging the preparation? Yes, we can, but sometimes the preparation is already large. So we have to know what to do afterwards. And we have also there to explain to the patient that there is, when it is already large, apical resorption or enlarged because of the primary treatment, we have to deal with this. But what Bart showed is very, very important. And on some of the micro CTs, I saw this without explaining it. It is very important to have the mechanical removal first, then what I call, and we call all, the supplementary approach. The supplementary approach is the activation. The activation can be done with ultrasonic activation, sonic activation, for example, the eddy, or with a finisher 5, for example, or even with, some cases, with laser, if we are using laser. So we have to use some activation. I am personally using, in most of my cases, ultrasonic activation. I think you too, Bart, you are using ultrasonic activation? Yeah. It's a choice. The only problem with the ultrasonic activation is we are using metal, so we have to make sure, first of all, that the metal is not touching the walls, because if it's touching the walls, we can do iatrogenic transportation, and also if it's touching the wall, we won't have a good acoustic streaming and cavitation. So it should not touch at all the walls. So the canal should be large enough to accept this ultrasonic tip inside it, which is not the same for the sonic activation. If you are doing sonic activation, like the eddy, you are working also not only on the frequency, which is lower than ultrasonic, but also on the amplitude of the tip.
Okay, so there's a question for me. Can you mute the microphone, Mark? Right. There's a question about what is the best fitting material for retreatment for healing. Actually, to be honest, as Mark mentioned, the beautiful study from Mahmoud Torabinejad, the MTA in many cases, especially perforations, open apex cases, this is the great filling material. But mostly in like 90% of cases, I use gutta percha and the AH plus sealer. This is the golden standard. As long as you can achieve the talc back, as long as the apical preservation, the apical constriction is preserved, you can use it, and it doesn't matter. I've shown you the I've shown you the case with the bioceramic material only because there was a huge absorption of the apex, so I should put their MTA, but the control of MTA in the very end of a long route, especially when we have external and internal absorption, would be very hard. So it was easier to place bioceramic sealers, and that's all. But normally I use gutta percha and the resin-based sealer. If there is a radiolucency in a single root and the other root has no apical evidence, can we treat the single root? On the one hand, I believe we can treat the single root, but in practice, I do it very, very rarely. Because in most of these cases, more or less, there are many things to improve. So in like 98 or 99 even % of cases, I do the whole retreatment and I treat the whole tooth. In very rare cases, I can treat only the MB2. I sometimes it's like 1 or 2 patients per year that I treat the single root. That's all. Another question: endo crown or post and crown? Post and overlay. What do you say, Mark? I say post and overlay. How about you?
Well, in my opinion, it depends of how many walls we have. Of course, if we have a deep pulp chamber, in my opinion, we can in some cases not use posts at all. If we have nice 3 walls, we can, in cases like this, do an endo crown without going inside the canals. But I agree also with Bart, because in most of the cases that you are treating, we don't have 3 walls. It's very rare to have 3 walls. When we have 3 walls, usually we are conservative and we are not doing root canal treatment, so we are not. But if in some special cases we have 3 or 4 walls, I think we can go without a post. I don't know if you agree.
Yes, I believe so. Okay, so ladies and gentlemen, I believe there are no more questions. So nevertheless, we had some issues, but finally we fight with them. So Mark, I would like to say thank you very much for the brilliant presentation. You did a lot of study. I don't know if our participants have noticed, because we've been quoting some researchers, but Mark has done it by himself, many things, and he was showing his graphics, his 3D reconstructions. There is hell of a job. He really done impressive job. So it's more valuable for the webinar and for the participants, because also connected with own experience. So thank you very much, Mark, for all the effort. And beautiful afternoon. Fortunately, we have the same time zone, so we have afternoon.
Thank you, Bart, and also I thank you for your beautiful pictures. Really, it's one of the best for the pictures of the pulp chamber. I don't know what is his secret. I don't know what is his secret. Maybe one day he will teach me.
I believe we can teach and learn from all of us, each other.
Sure.
There's huge things to learn and to share.
Yes, of course.
Do you want to add something, Mark?
No, I think we're all done. I hope we gave some answers, simple answers to the retreatment cases that we are doing every day as endodontist, probably a general dentist.
I hope so. So, ladies and gentlemen, thank you very much. Enjoy your, I don't know, morning, middle day, afternoon, maybe evening, because you're watching all around the world and we know it. So have a good day, have a good time. Thank you, Mark. Thank you, ladies from the Endostar, which are providing us, the lecturers, and all the stream. They are doing a lot of job also. So thank you very much, ladies. And I hope to see you soon all. Thank you very much. Bye.